Welcome to another episode from the Veterinary Research Channel. Today, we delve into a fascinating case report published in the Journal of Veterinary Internal Medicine in 2023. This study, authored by Matthew M. E. Steele, et al., details the successful surgical treatment of a dog suffering from a rare condition known as hypersomatotropism, which arose as a consequence of a tumor in the pituitary gland that produced excessive growth hormone. Hypersomatotropism, also referred to as acromegaly, is a condition characterized by an overabundance of growth hormone in the body. This hormonal excess can lead to a variety of physical changes and often results in a state of diabetes mellitus that is resistant to insulin. In dogs, acromegaly stemming from a growth hormone-producing tumor, specifically a pituitary somatotroph adenoma, is considered a rare occurrence, and documented instances of successful treatment are limited. This case report aims to contribute to the understanding and management of this condition by presenting the diagnosis, treatment, and outcome of a dog with acromegaly and concurrent diabetes mellitus that was surgically treated using a procedure called Transsphenoidal Hypophysectomy. This particular case involved a 6-year and 10-month-old male neutered Patterdale Terrier who was brought to a veterinary referral center. The owners reported a 3-month history of increased urination and thirst, weight gain, lethargy, a longer hair coat, and noisy breathing during inhalation. Upon physical examination, the veterinary team observed several notable features, including broadened facial characteristics, enlarged paws, and an increase in the length of facial hair. Furthermore, the spaces between the teeth were wider than normal, and the dog exhibited a slight underbite of the lower jaw. A mild, noisy breathing sound originating from the pharynx was also noted. Initial blood work and urine analysis did not reveal any significant abnormalities, and the dog was not showing signs of glucose in the urine at this stage. Tests to evaluate thyroid hormone levels indicated normal thyroid function, and a test to assess for Cushing's disease, a condition involving excessive cortisol production, also yielded results within the normal range. However, the concentration of insulin-like growth factor 1 in the dog's serum was significantly elevated at 1,783 nanograms per milliliter, which is above the threshold of 1,000 nanograms per milliliter typically associated with acromegaly in dogs. To further investigate, the dog underwent magnetic resonance imaging of the head, which revealed a moderately enlarged pituitary gland measuring 6.4 millimeters in height. The appearance of the gland on the magnetic resonance images suggested a mass. Computed tomography scans of the head, chest, and abdomen confirmed the enlarged pituitary gland, which showed uniform enhancement with contrast and also indicated thickening of the soft palate and pharyngeal tissues, as well as thickening of the outer layers of the bones in the upper and lower limbs. Mild enlargement of the liver was also noted. The owner opted for surgical intervention to address the pituitary mass. In the week leading up to the scheduled surgery, the dog's clinical signs worsened. The increased urination and thirst became more pronounced, and the dog was found to have glucose in the urine and elevated blood glucose levels, with a starved blood glucose reading of 502 milligrams per deciliter. These findings were consistent with the development of diabetes mellitus. Consequently, the dog was started on subcutaneous injections of insulin lente twice daily. The dog was then transferred to another specialized center, the Royal Veterinary College Small Animal Referral Hospital, for the transsphenoidal hypophysectomy procedure. Repeat blood tests confirmed the previous findings, and the serum fructosamine concentration, another indicator of long-term blood glucose control, was also above the normal range. The preoperative insulin-like growth factor 1 level was 1,558 nanograms per milliliter. The transsphenoidal hypophysectomy was performed under general anesthesia without any reported complications. This surgical technique, which involves accessing the pituitary gland through the sphenoid bone at the base of the skull, was conducted largely following established procedures, with the addition of a surgical head clamp to ensure stable positioning. The entire visible portion of the pituitary gland, described as cream-colored, was removed using a combination of specialized surgical instruments and gentle suction. Following the removal, a small rigid endoscope was used to inspect the pituitary fossa and confirm that no macroscopic remnants of the gland remained. The surgical site was then closed using standard techniques. Postoperative computed tomography imaging confirmed the removal of the pituitary mass, showing a defect in the basal sphenoid bone and an air-filled cavity in the area where the pituitary gland had been. The dog recovered quickly after surgery without experiencing any immediate complications or neurological deficits. Intravenous infusions of insulin and hydrocortisone, a type of steroid hormone, were discontinued within 12 hours after the operation, and oral hormone supplementation was initiated. This included hydrocortisone twice daily and levothyroxine, a thyroid hormone replacement, once daily. Desmopressin acetate, a synthetic form of antidiuretic hormone, was administered into the conjunctival sac of alternating eyes every 8 hours to manage potential postoperative diabetes insipidus, a condition characterized by excessive urination due to a lack of antidiuretic hormone. Oral antibiotics were also given for 2 weeks to prevent infection. In the immediate postoperative period, the dog experienced an increase in serum sodium levels, which peaked at 177 millimoles per liter. This electrolyte imbalance was likely due to the temporary lack of antidiuretic hormone following the removal of the posterior pituitary gland. The hypernatremia was successfully corrected within 6 hours through the administration of oral free water, which the dog could drink voluntarily, and intravenous fluids of a dilute saline solution. No neurological signs were observed in association with these sodium fluctuations. The dog's blood glucose control was variable initially, with episodes of high blood sugar after meals that subsequently returned to normal without the need for additional insulin therapy. The histopathological examination of the removed pituitary gland revealed a pituitary acidophil neoplasm. Immunohistochemical staining confirmed that these neoplastic cells were positive for growth hormone, indicating that the tumor was indeed producing this hormone. The tumor tissue showed a uniform population of polygonal cells that stained positively for growth hormone and had disrupted the normal structural framework of the pituitary gland. These findings were consistent with a growth hormone-producing pituitary neuroendocrine neoplasm, or somatotroph adenoma. The dog was discharged from the hospital 4 days after surgery. At this time, the serum insulin-like growth factor 1 concentration had decreased significantly to 396 nanograms per milliliter. The dog returned for a follow-up examination 11 weeks postoperatively. Shortly after being discharged, the dog's blood glucose levels remained high, and insulin-like therapy had to be restarted and gradually increased to a dose of 0.3 units per kilogram of body weight twice daily. However, the increased urination and thirst had resolved, and there were visible signs of improvement in the physical characteristics associated with acromegaly, including a return to normal hair length and facial appearance, and the noisy breathing during inhalation had ceased. Blood tests at this time showed a normalization of a previous mild anemia, and other blood chemistry parameters were within normal limits, except for mild hypoglycemia and an elevated fructosamine level. Importantly, the serum insulin-like growth factor 1 concentration had further decreased to 49 nanograms per milliliter, which was considered consistent with biochemical remission of hypersomatotropism. The total thyroxine level was also within the normal range. The owners reported that the dog was mildly lethargic and exhibiting heat-seeking behavior, which subsequently resolved with an increase in the oral levothyroxine dosage. The administration of desmopressin was switched from conjunctival drops to oral tablets due to concerns about potential eye irritation. 6 months after surgery, the serum insulin-like growth factor 1 concentration remained low at 35 nanograms per milliliter. At the 12-month follow-up, the dog was reported to have normal energy levels with no recurrence of the previous clinical signs of hypersomatotropism and normal water intake. The dog continued to receive the postoperative hormone replacement medications and a reduced dose of insulin-like at 0.25 units per kilogram twice daily. The authors of this case report discussed several important aspects of this case. They highlighted that this was an instance of a dog with diabetes mellitus caused by acromegaly due to a pituitary somatotroph adenoma that was successfully treated with transsphenoidal hypophysectomy. The clinical signs associated with hypersomatotropism, such as changes in the hair coat and noisy breathing, resolved within 11 weeks after surgery. Furthermore, biochemical remission of hypersomatotropism was achieved and maintained for the 12-month follow-up period. Despite the improvement in the signs of acromegaly and some improvement in blood glucose control, the dog remained diabetic. This led the authors to consider the possibility that the diabetes mellitus might have developed independently of the acromegaly in this dog, or that irreversible damage to the insulin-producing beta cells of the pancreas had occurred as a result of the prolonged exposure to excessive growth hormone. The definitive diagnosis of hypersomatotropism in this case was based on a combination of the dog's clinical signs, the elevated serum insulin-like growth factor 1 concentration, the identification of a mass in the pituitary gland through advanced imaging techniques, and the findings from the histopathology of the removed pituitary tissue. The histopathological features observed in this dog, including the proliferation of acidophil cells and their positive immunostaining for growth hormone, were consistent with the few previously reported cases of acromegaly in dogs and align with the diagnostic criteria for pituitary somatotroph adenomas in humans. While various subtypes of growth hormone-producing tumors have been described in humans, based on detailed pathological and molecular analyses, such classifications are not routinely used in veterinary medicine. Pituitary acidophil tumors can sometimes secrete both growth hormone and prolactin, but prolactin staining was not performed in this case, and its clinical significance in dogs with acromegaly remains unclear. In addition to the pituitary mass, the computed tomography scans also revealed thickening of the bone cortices in the limbs, a finding that, while subjective, could be consistent with the bone thickening observed in the skulls of cats with acromegaly. The authors emphasized that in human medicine, pituitary surgery is the preferred treatment for acromegaly due to its high and rapid remission rates. Transsphenoidal hypophysectomy was chosen for this dog due to its potential to achieve both biochemical and clinical remission of hypersomatotropism, based on the positive outcomes reported in humans and, increasingly, in cats. Recent studies have demonstrated the effectiveness of transsphenoidal hypophysectomy in treating diabetes mellitus caused by hypersomatotropism in cats, with high rates of diabetic remission and extended survival times. This surgical approach is also a well-established treatment for other pituitary conditions in dogs, such as pituitary-dependent hypercortisolism and non-functional pituitary tumors. The discussion also compared this surgical case with a limited number of previously reported treatment modalities for acromegaly in dogs, which primarily involved conventional radiation therapy and medical management. In those cases, radiation therapy often did not lead to immediate resolution of clinical signs or normalization of insulin-like growth factor 1 levels, although improvement was sometimes seen with subsequent medical treatment using pasireotide. While newer radiation techniques like stereotactic radiation therapy have shown promise in treating hypersomatotropism and diabetes mellitus in cats, the rates of diabetic remission are generally lower compared to surgical management, and less information is available regarding changes in insulin-like growth factor 1 concentrations. In the current case, the rapid and sustained decrease in serum insulin-like growth factor 1 levels following surgery strongly indicated the effectiveness of transsphenoidal hypophysectomy in achieving biochemical remission of acromegaly in this dog. The authors suggested that surgical treatment should be considered as a primary option for dogs with growth hormone excess resulting from pituitary adenomas, as it offers the potential for a more direct and potentially curative approach by removing the hormone-producing tumor, in contrast to medical management which aims to control hormone levels. The development of transient hypernatremia in the postoperative period was noted as an important complication. This was likely a consequence of iatrogenic central diabetes insipidus due to the sudden loss of antidiuretic hormone secretion after the removal of the posterior pituitary gland. The authors emphasized the importance of closely monitoring serum sodium levels in dogs and cats following hypophysectomy and being prepared to manage any imbalances with fluid therapy, electrolyte supplementation, and the use of synthetic desmopressin. Finally, the case highlighted the unusual presentation of the dog, which initially did not have overt diabetes mellitus at the time of diagnosis of acromegaly, but developed it subsequently and remained diabetic even after the successful treatment of hypersomatotropism. This contrasts with a more typical scenario in cats, where acromegaly is often diagnosed in the context of insulin-resistant diabetes mellitus. While diabetes mellitus associated with acromegaly, due to growth hormone production from mammary tissue, is variable in dogs, most reported cases of pituitary-dependent acromegaly in dogs do present with overt diabetes or impaired glucose tolerance. The presence of increased urination and thirst before the onset of overt diabetes in this dog suggests that impaired glucose tolerance might have been present earlier, although this was not definitively confirmed. In conclusion, this case report provides valuable insights into the diagnosis and successful surgical management of hypersomatotropism secondary to a pituitary somatotroph adenoma in a dog. It demonstrates that transsphenoidal hypophysectomy can be an effective treatment for achieving remission of acromegaly in dogs, although the resolution of concurrent diabetes mellitus may be less predictable. The study underscores the importance of considering this surgical technique as a viable option for dogs with this rare endocrine disorder and highlights the need for careful postoperative monitoring and management. Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.